Welcome to a special presentation of Charter California Edition, brought to you by Charter Communications, the California Telehealth Network, and the California Channel. My name is Brad Pomerance. I'm very glad you're with us. Over this hour, we're going to be speaking with experts, specialists on the issue of telehealth and telemedicine. It's my pleasure to introduce you to a few of our panelists. We are joined first by Assemblyman Bill Monning. Mr. Monning was elected to the California State Assembly in November of 2008. He represents portions of Monterey, Santa Cruz, and Santa Clara counties. He is currently the chair of the Assembly Committee on Health, and he was instrumental in establishing California's Health Benefit Exchange. Prior to joining the Assembly, he was a professor of law at Monterey College, and his wife is a family physician. Her name is Dana Kent. Then we are joined by Linda Halderman, Dr. Linda Halderman. She is a board-certified general surgeon who specializes in breast cancer diagnosis and treatment. Fluent in Spanish, Dr. Halderman serves rural, uninsured, and underinsured women with breast cancer in South Fresno County. In 2009, she provided medical relief for 3 months to the U.S. territory of American Samoa. She will be leaving the Assembly to go back to the full-time practice of medicine, and we congratulate her on that decision. She is also the elected chair of the California Legislative Rural Caucus. And then it's my supreme pleasure to introduce you to Eric Brown. He is the president and CEO of the California Telehealth Network. He most recently served as executive vice president of affiliate relations for Herring Broadcasting and the Africa Channel. And prior, he was president of the Western Division of none other than Charter Communications. And he served as president of the Minnesota Division of Time Warner Cable. He had been the past chairman of the California Cable and Telecommunications Association. Dr. Richard Pan will be joining us. Dr. Pan, of course, is a member of the California State Assembly. We'll introduce him when he arrives. So I want to thank the three of you for joining us very much. I want to start and try to get a sense of the scope of the issue that we're dealing with. And what we're dealing with here is we are in a state that is 85% rural. 44 out of 58 counties are rural. Over 5 million Californians live in rural areas. And where there are rural areas, there may not be doctors. There may not be nurses. Can we start with you, Dr. Halderman? You are the chair of the Rural Caucus. Talk to us about the scope of the issue.
When you look at the area I represent in the Central Valley, it starts around Fresno and goes out from there. Our valley is underserved for primary care physicians by 25%, for specialists by 50%, and for mental health professionals, we're underserved by 75%.
And I understand that because of that, many primary care physicians, those that even exist, are being forced to spend 20-25% of their time on mental health issues, when that's really not their area of expertise.
Well, I think in a lot of ways they have a great deal of experience dealing with that. But when you come to an issue like, for example, a schizophrenic teenager, there's a real benefit in having a mental health professional who specializes, and we just don't have that.
Assemblyman Monning, you represent the beautiful Central Coast, and we think of these very majestic areas, but in your district, there is also some rural areas. Talk to me about what you have seen in your communities as it relates to the dearth of medical professionals.
Thank you, and Brad, thanks for this opportunity, and thanks to Charter. The three counties you mentioned, Santa Clara, Santa Cruz, and Monterey counties that I represent, all have significant rural area. Number one employer is agriculture, followed by hospitality tourism. We have the highest number of adults with a 6th grade education or less in Monterey County. That leads all of the 58 counties in terms of a percentage of population with 6th grade education or less. This is the workforce. It's the workforce that generates the success of the business community in agriculture, hospitality, tourism, and yet that workforce has health care needs. We also find in these demographics higher trends in poor health in terms of child obesity, preventable diabetes, heart disease, preventable asthma. And that's a function often of air quality. Sometimes in rural areas you have a combination of a lot of diesel use, pesticides, etc. So particularly impactful on children. So all of this requires medical infrastructure I believe we need to not just look at treatment protocols, but more invested in the prevention side, the promotion of wellness. We need a healthcare system that's built on building healthy communities, not just treating broken bodies.
Mr. Brown, can you talk to us in a more California sense? How severe is the problem? We know Fresno has an issue. We know that Monterey has an issue. But what about the state generally, since you are the president of the California Telehealth Network?
Yeah, no, I travel. I try to spend at least 2/3 of my time on the road, out in the communities, witnessing firsthand what the conditions are. And it's hard to explain to folks who have not been to truly rural areas in California.
It is remarkable because we are such an urban state.
Right.
We think of Los Angeles,
Right.
San Diego. I was looking at some statistics. 5.3 million live in rural California. Right. That is more than the city of Los Angeles
Right.
and the city of San Diego.
Right.
And yet we're so myopic about our fellow Californians.
Right. And I often have to remind my own stakeholders that who live in Sacramento or the Bay Area or San Diego or Los Angeles, that our reality is a very different reality than folks who live in Modoc County or Imperial County or Inyo, Mono County. Many of the communities we serve are truly frontier, less than one person per square mile, if you can imagine that, which many people cannot. So there are profound infrastructure issues to begin with, and then you overlay the healthcare challenges that these communities have, where in order to be seen by a primary care or specialty care clinician, very often you have to travel great distances, and many of the folks in these communities, particularly those at the lower end of the economic scale, don't have the wherewithal to be transported great distances. If they are able to do that initially and get diagnosed, for most of the chronic conditions or diseases, very often it requires a lot of follow-up visits.
And that's where the concept of telehealth, telemedicine comes into play. So for our panel, for our audience, what exactly is telemedicine? What exactly is telehealth? Is there a difference between the two?
There is a difference between the two. Telemedicine is a subset, if you will, of telehealth, which is basically using telecommunications to provide or assist with healthcare delivery. Generally, it focuses on addressing situations where you have people who would have to travel great distances to receive healthcare delivery. Healthcare delivery, by the way, in the sense of telehealth, could also mean healthcare education for clinicians, patient information around nutrition or how to take control of their lives and managing their own conditions. Telemedicine tends to focus more on the clinical delivery of healthcare using telecommunications.
I think the key is you're literally using electronic information and communications technologies to provide and support health where distance separates the participants. I mean, I think I got that from your website.
Yeah.
It's really that simple. And you know, here we are in Sacramento, a major center, in Los Angeles, wherever it may be. It's just foreign to us.
Yeah. But even I would say in urban areas, part of this implementation of telehealth includes converting paper records to electronic medical record systems. That's happening across the board, not just rural but urban areas. It's a key component of the Affordable Care Act. California's already received significant resources for the implementation of electronic medical records. And so I think that's also an important subset when we talk about telehealth. It's using current technology to, in the ideal, enhance patient health care access, education, and to bring providers also into the 21st century in terms of an ability to more effectively manage patient health by being able to manage records, share records. But I know we'll get to this. Within that will be certain concerns about patient confidentiality, et cetera.
Doctor, I'd like to ask you, as someone who has been on the ground, to really give us, I don't know if it's a single anecdote of how this manifests. You know, we can talk about it generally, but in your practice, have you had a case where the use of telemedicine could have or did assist in the final outcome?
Absolutely. First of all, we have to recognize that about 15% of our state has no cell coverage, and so there are technology issues.
And we'll talk about that for sure.
But let me tell you about one of the most amazing stories. As I was serving in American Samoa,
Right.
we had a relationship with Hawaii Shriners. And so what we did is, as a child was healing from an orthopedic injury that had been repaired at Shriners in Hawaii, 5.5 hours plane flight away, we were able to connect using technology to allow evaluation of the angle, make sure that the child was healing properly, so that our orthopedic surgeon, who had limitations on the island, was able to utilize the expertise of incredible orthopedic surgeons on Hawaii.
I know UC Davis, for example, is using telehealth, telemedicine in a very effective way. Apparently, and I've learned this through my research for this panel, many children who are born with potential auditory issues, you get tested on the day of birth, they won't have follow-ups because they live simply too far away. And so UC Davis has launched a program whereby the mother, the father, simply puts the probes on the child's head and the information is sent to a doctor's laptop. It's really that simple. And so if the child does need further follow-up, then they have the information. But to just bring the child in for a maybe, parents may not want to do that.
But there are also uses that I think are not just limited to rural. For example, in my little town, we had a grand total of 1 radiologist. And bless his heart, he didn't need to be awake 24/7.
Yeah, he should have been.
So it was wonderful. But
Right.
instead of that, we utilized time zones, and we telehealthed our radiology images to Australia, which is daytime. And
This
so,
is when you were in American Samoa?
no, this was when I was practicing in Selma,
Oh, you're
California.
kidding. Oh, so
And so we utilized that as a way of conserving the resources we had instead of burning out our 1 radiologist.
let me ask you, though, about, for example, radiology, because to me, that is an area where telehealth can be the most exciting, but also, one could argue, a bit precarious. If the broadband connection is not what it should be. I think about breast cancer diagnosis. I mean, from what I understand, the smallest little imperfection needs to be picked up precisely. And if your high-speed medical-grade broadband connection is not what it should be, you could miss something. But I know you're working to make sure that the broadband connections, and Charter, and of course, but the broadband connections are at the level they should be.
Right.
Talk to us about that.
That was the whole genesis for the formation of the California Telehealth Network, to create a statewide broadband network dedicated to the delivery of health care. This is different in many ways than broadband is that many of our residential folks know in terms of usage, in that this is a closed network. The participants in the California Telehealth Network all have direct connectivity to each other as healthcare providers. It is totally, the traffic that travels over our network is not exposed to the public internet.
So that's part of the confidentiality issues.
Correct, security and safety. And then the third thing is there's guaranteed quality of service, and I won't get into the engineering and technical aspects of it, but this is a technology that we use. AT&T is our statewide vendor that's been used for years by the Department of Defense or the
When we
financial
come back,
services
sir, I want to
industry.
talk more about delivery, though, because I do think it's an important issue. We're speaking with Assemblyman Bill Monning, Assemblywoman Linda Halderman, President of the California Telehealth Network, Eric Brown. I'm Brad Pomerance. We'll be right back on Charter California Edition.
What percentage of Californians has participated in a telehealth seminar? 3, 5, 8, or 10%? According to the California Healthcare Foundation, as of 2007, only 3% of Californians had participated in at least one telehealth session.
Welcome back to a special presentation of Charter California Edition. My name is Brad Pomerance. You are joining a panel discussion about telehealth, telemedicine, brought to you by Charter Communications, the California Telehealth Network, and the California Channel. We are joined by Assemblyman Bill Monning, Assemblywoman Linda Halderman, the President of the California Telehealth Association, Eric Brown, and Dr. Richard Pan has joined us.
Thank you.
We thank you for joining us, Dr. Pan. I want to tell you a bit about the Assembly member who represents the cities of Sacramento, Citrus Heights, and Folsom. He is a UC Davis educator and pediatrician, director of the UC Davis Pediatric Residency Program, co-founder and chair of Healthy Kids, Healthy Future. He was awarded in 2010 the Physician Humanitarian Award from the Medical Board of California. He married up. Dr. Wang is his wife. She is a dentist. And I might mention that there are, we'll just say 4 doctors in the California Assembly and Senate. Dr. Halderman, Dr. Pan, Dr. Bill Emerson, a member of the Senate, is a dentist, and Dr. Ed Hernandez is an optometrist. Other medical professionals, but 4 true doctors. So Dr. Pan, we've been speaking a bit. I want to get your sense of your view of the issue of telehealth, telemedicine, and the scope of the challenge.
Well, telehealth actually presents a tremendous opportunity to meld 2 large fields, healthcare, and particularly healthcare delivery with information technology. And I think we're just scratching the surface. Right now, as we're rolling out electronic medical records, electronic health records, as some people are saying, that is basically allowing not only physicians and other health professionals to communicate with each other, but also patients to interact in a different way. That certainly is an initial step. But I think more excitingly is that being able to move the expertise of various health professionals over distance and time, and that's something that's going to improve access.
It's interesting, you weren't here, but Dr. Halderman talked about moving expertise across time because she was serving in a rural community in Fresno County, needed a radiologist, and her radiologist
One radiologist.
was sleeping. So who was your radiologist for the day?
The awake and alert Australians.
There you go.
And it shows how innovative the solution can be. We also discussed how at UC Davis, an institution you know well, I guess there's a pediatric oncologist, Ann Simon, I don't know if you know her, but she is using telehealth for babies who are born.
Right.
You know, they get their screening for hearing. There may be an issue, but they live far away. They don't come back for follow-ups. They put the probes on their heads. At home, the information is transported back to the laptops. If they need to come back in, they come back in.
No, and I think that's one example. There's other examples. So, for example, again at UC Davis, they have a setup in the intensive care unit where they communicate with different emergency rooms in rural hospitals where there aren't pediatric specialists there. And when a child shows up in the emergency room, used to be without telehealth, what would happen is they'd say, it's a child, we're not sure how severe the injuries are. Well, let's just call the transport team, send the ambulance or helicopter out, pick them up, bring them over to UC Davis or some other trauma center. Now what can happen is the child comes in, they can actually communicate through telehealth, they can get the information, put the monitors on, get the information directly, and then actually make a decision there about does the child actually need to be transported. And also what more importantly is that they can now start advising the physician on the scene what they need to do to stabilize the child. Because even when you call the transport team, it's another half hour, hour plus to get over there. And so we need to be sure they get the right kind of care. Trauma, the golden hour is very precious.
Right.
And you can actually start being sure the right things are done with people who are experts in that
And
field.
I do want to talk about the cost savings, the potential cost savings during this hour, but I want to go back to you, Mr. Brown, and talk about how the technology is delivered, because we talked about that today we are ensuring that the connectivity is high-speed, medical grade. But I understand that, I guess the U.S. Department of Health and Human Services estimates there are about 200 networks throughout the nation. About 2,000 institutions are linked. That doesn't seem like a lot. It doesn't seem like a lot for a nation, let alone California.
Well, here with the California Telehealth Network, we've enrolled just over 400 healthcare providers. Most of these are federally qualified health centers, are critical access hospitals, community health centers, and hospitals. And bear in mind that many of them, prior to the CTN being formed, had their own connectivity. So think about Kaiser, for instance, as a network of providers. They have their own telehealth network. and would not be included in the numbers that we're talking about. So it's a phenomenon that is growing and evolving. I will tell you that one of the most profound needs that we have seen over the last couple of years as we've deployed our network here in California, particularly in urban areas, but not exclusively, particularly in rural areas, but not exclusively, is that one of the barriers is that many of these sites don't have the technical expertise to take advantage of the technology that we're deploying.
And along the same lines, there's a term that I guess you use in your industry, last mile connections. Right. That so often in rural areas like the ones you represent, they just can't get to that last mile. Is there anything that please, Mr. Monning?
Well, it's a critical issue. I carried legislation last year, Assembly Bill 278, that was signed into law, and it's established some pilot projects to establish efficacy of telehealth, looking at all the aspects. What you allude to is the technology connection available. One of the issues critical to my legislation was also preservation and integrity of patient information, the confidentiality of that, which is absolutely essential in the healthcare arena, and particularly when we start sharing records where it can facilitate treatment and care to make sure there's not an unintended misuse or sharing of patient data. The other final comment, if I might, is also a critical concern is that I am a huge fan of telehealth, of telemedicine. It can really facilitate some of the examples we've heard. We just need to be mindful and careful that we don't supplant a direct doctor-patient connection or provider-patient connection where that touching, listening, and human interaction cannot be supplanted through an electronic connection.
Let's talk about that balance.
Yeah, I'd like to follow up on that because I think what Senator Monning brought up is very important. We've seen multiple studies that looked at the relationship between the doctor and patient and how that can improve the quality of care and the health outcomes. You do need that personal connection. You need to have that level of trust because if a physician who asks a patient to do something, they're not going to do it if they don't have that trust relationship. And in fact, I think most of the more successful models of looking at telehealth is that you do have someone who's on site who has a direct physical interaction, and you may have, what happens is we're trying to support that relationship by providing information, specialists who can provide, there may be other people the patient may interact with, but eventually it does then come down to that doctor-patient relationship. We're actually empowering and expanding on that using telehealth, and that's how it's going to be successful.
That's the ideal model because the treating practitioner can bring in these other resources. We've heard anecdotal complaints, and there's been a journal article on this, of doctors who now are trying to adapt to the electronic medical record. The patient's in their exam room, and the patient sees the back of the physician who's furiously trying to get all the information into the computer, and it can reduce that healthy interaction between doctor and patient. It is being addressed. Doctors are putting the laptop in a placement where both patient and doctor can look at it together. The patient can see what's being inputted. But again, it's a learning curve for all, for practitioners as well as for patients.
Well, so as you know, and it's along these same lines, California was really the forerunner when it came to telehealth, telemedicine, when the state passed the 1996 Act, the Telemedicine Development Act. And as part of that groundbreaking legislation, there was this concern about patient resistance on the one hand, and then patient overuse on the other. And so how have you seen that those competing challenges play out? Because that really goes to what you're saying, Mr. Monning.
Well, one example would be the Kaiser system is probably the premier health delivery system that does rely on electronic connection, not just of medical records, but between treating physicians and practitioners and patients, where people can access from home lab results, things like that. It's a tremendous model. What we have to recognize, though, in rural areas, lower income Californians won't necessarily have the technology at their end to take advantage of that, to be in connection remotely with a practitioner.
Yes.
And I think the other part, when you talked about both the patient resistance and patient overuse, some of this is also, of course, is that the patients and their families experience over time with information technology. So if you think about how much information technology has changed and how it used to be you called a travel agent, now practically everyone's online doing their own searching. So that experience, I think, then informs them, and of course their concerns about things like privacy, right? That you start hearing about cookies and privacy issues, so that's why we need to be sure as a legislature.
But is the privacy really, is that question it's a solution searching for a problem? I mean, in the final analysis, I want to be healthy.
Well, there's
It's
been
a massive problem.
Yeah.
It is?
Go ahead.
Most certainly already a massive problem. Data mining is common, and we have learned this the hard way. So patient data protection is critical in information technology.
Other than the obvious reasons why we'd want our privacy protected, what's the harm if someone finds out that you're...
there have been breaches of patient confidentiality, everything from just identification and social security number to very intimate personal questions about certain diagnoses, HIV, AIDS, etc., can lead to jeopardizing employment.
We talked earlier about trust. So the problem is that if whether your privacy has been invaded or not, if you think it's at risk and you don't have that trust. When I see a patient, when Dr. Halderman sees a patient, we expect that when we have that conversation that they will divulge some of the most personal information that they may not even divulge to other family members to help us take care of them. If they don't feel comfortable doing that through this electronic medium, and that's how we're communicating with them, then we are not going to be able to take care of the patient effectively. And that's really why the privacy issues is so important.
So today, is the privacy of the patient being protected via telehealth, telemedicine channels?
Sometimes.
Oh, really?
I think it is improving on an almost daily basis because people are so aware of it, and we've got such better technology today. Unfortunately, there are those who make a living off of data mining, and that's where we get in trouble.
And just a comment, data mining is where companies consciously want to learn more about the prescribing habits of physicians, for example, to inform their marketing and advertising.
Corporate espionage.
Well, it's legal. You have pharmacies who routinely report the prescriptions that they are fulfilling for a patient. They protect the patient identity, but the prescribing physician's information is shared, and then that results in follow-up with that physician. If he or she's not prescribing brand names but is using generics, then the objective is to try to boost your treating physician to maybe convert you from a generic to a name brand.
On the
But that's not a breach. That's
No, I
just
hear you.
current marketing practices. Right.
So on the technology side, where are we on the privacy questions, which clearly are critical?
They are critical, but I think, as was mentioned, the technologies are improving. Healthcare has really been kind of slow to adopt the available technologies. If you look at financial services, if you look at entertainment, in some respects, in terms of how they manage personal information. Now, it's not medical information, but it's financial information, personal information. There are ways to do this. There are standards and specifications that can be set to make sure that people's right to privacy are protected. That's going to become critical in healthcare because not only do we need to collaborate more on the patient's information, there are models being built now to build better clinical decision support tools.
Okay, so when we come back, I want to talk more about that. And I also want to talk about a bill that was signed by the governor, a bipartisan bill that was signed, the Telemedicine Advancement Act of 2011. It really changed the face of the future of telemedicine. I'm Brad Pomerance. We'll be right back on Charter California Edition.
How much would California save upon a full deployment of telemedicine services on an annual basis? 51, 161, 271, or 511 million? According to the California Telemedicine and eHealth Center, the complete deployment of telemedicine services would save California $511 million annually.
Welcome back to Charter California Edition. I'm Brad Pomerance. You are joining us on a special presentation of a panel discussing telemedicine, telehealth. It is brought to you by Charter Communications, the California Telehealth Network, and the California Channel. We are joined by Assemblyman Bill Monning, Assemblywoman Dr. Linda Halderman, Eric Brown, the president of the California Telehealth Network, and Dr. Richard Penn, also a member of the California State Assembly. I do just want to clarify that telehealth, telemedicine includes not just electronic records, but it can deal with specialists offering diagnoses, patient consultations, remote patient monitoring, even continuing medical education.
Absolutely.
I mean, you need to get continuing medical education hours, and if you live in Selma, California, you can't get to the big city.
It is it's invaluable is what it is, especially in the most remote areas where we want access to the academic minds to be on the forefront, and it's a difficult thing to do when the nearest big city is 70 miles away.
And that can be challenging. I do want to mention that California continues to be a forerunner in the area of telemedicine, telehealth. In October of 2011, the Telemedicine Advancement Act was signed, a bipartisan bill, which is very nice in Sacramento. Why don't you start, Dr. Pan, give us the scope of the importance of this act.
Well, this act is very important because basically we need to continue to not only advance telemedicine and telehealth, but bring it into the mainstream and make it sustainable. I think one of the challenges for many of people who've been working in the telehealth arena is that people have set up different systems and different models. However, because there were challenges with being able to bill for services that are provided, and that's time. There's challenges with trying to set up infrastructures. Challenges with how do you define this new relationship using telehealth?
Well, I know, for example, that now under the 2011 Act, telephone calls are included.
Yes.
Email is included. I mean, who would have thunk that email wouldn't be included in the definition of telemedicine, but it wasn't under the 96 Act.
Right, and telehealth is about moving information around, and we talked earlier about in space and time. So there's many different modalities to do that, and what we want to be sure, though, is that when we create these models, we're going to be able to move this information to rural communities, to underserved communities, even in urban communities, et cetera, that we can actually develop sustainable models, that we actually recognize that services are actually being delivered, they need to be supported.
It also expanded the location by which a medical professional could be in order to allow for coverage. Anyone want to talk about that?
Well, it's, as we look at the advent of expanded access and eligibility in California under the Affordable Care Act, 3 to 4 million Californians currently without health care insurance are going to become eligible in 2014. We're not going to have a commensurate increase in primary care physicians and other healthcare providers, so we're going to have to become even more efficient in the ability of using limited resources. Telehealth, telemedicine is one way to do that, but again, because a lot of the demographic of those who will be newly eligible for health care may not be from middle income or higher income families, they may not have the technology in their home to connect with lab tests or things like that. That said, they can still become a beneficiary if they're in a remote area of having access to better diagnostic evaluations or educational information that might be transferred not to a home computer that they don't have, but over television, Charter cable, for example, and others.
What about the definition of the medical professional? Because under the old Act, it was limited basically to doctors. Now it's expanded to all healthcare professionals licensed in California. How important is that?
Well, basically what we know is we're moving forward is that the team approach to care is something that we need to embrace. We know that many people have chronic illnesses. Fortunately, due to the success of medicine, that people with chronic illnesses are living longer, but they need ongoing care. If we're going to look at ways to save actually healthcare costs while maintaining quality, we need to do a better job of managing chronic illnesses. And telehealth.
And you don't necessarily need a doctor to do that. It can be a nurse practitioner.
You need a team. You need a team. And I think we need to move away from saying which professional do you need. You need a team. And that's what people are now understanding. So, you have physician-led teams that basically think about how do you provide this comprehensive care, where you not only have a nurse, you may need to you need a mental health professional like psychologists, social workers, et cetera. They all
And it
impact
could
your health.
include an in-home support service
Right.
provider who's not trained medically, but who, by being part of that team, can help somebody dealing with a chronic illness stay at home versus being institutionalized, where the cost to us, the taxpayer, the difference between being able to provide that ongoing care at home with a team approach.
So how important is it that the Act of 2011 expanded the definition to include all healthcare professionals? I mean, to me, it seems like it was
like
key.
everything, there are wonderful outcomes and there are unintended consequences. One of the unintended consequences is the fact that we have medical records in place in different areas that cannot talk to each other and cannot interface. We also have areas where, because there is no technology penetration, critical access hospitals, for example, they are going to be at an automatic disadvantage. There is no substitute for the relationship one-on-one between a doctor and the patient. And I think we can solve some problems and make healthcare more affordable, but we cannot replace that relationship.
No doubt. Dr. Halderman talks about how critical care hospitals may not be connected.
Right.
What can be done? What is being
Well,
done?
the good news is, I think there are 32 critical access hospitals in the state. 17 of them are already connected to the California
We're
Telehealth
getting there.
Network. And we're working
More than
on
half,
getting
barely.
to the balance of them. So again, that's the focus of what we do, is we focus on the truly rural and medically underserved areas in urban communities, to make sure that they not only have access to broadband, but they also have access to the expertise that they need. I might mention that the California Telehealth Network earlier this year brought in the California Telemedicine and eHealth Center, CTEC it's called. It's a federally funded agency here in California that assists sites that have never, if you've never done telemedicine before, now all of a sudden you've got this broadband connection that enables you to do that, but you're not sure how the patient should be presented. You're not sure what equipment you need or what investment your critical access hospital or rural hospital needs to make. We now have teams that go in and assist you with that and train you with that, so that not only do you have the technology, but you understand how to utilize it.
I want to ask also about insurance coverage as it relates to the 2011 Act, because in the final analysis, really insurance is the key component when it comes to cost and cost containment. You may know there has been a model statute that was released by the Center for Connected Health Policy, and they called for parity in coverage between in-person and telehealth coverage. I think it's fair to say that under the 2011 Act, that parity is not codified. What the 2011 Act says is it does not mandate coverage for telehealth, but it removes exclusions for certain categories or services, but you still need the negotiation between the insurer and the provider, including Medi-Cal. So talk to me about that element. I can see your mind is moving.
Well, I'm thinking in particular of the Central Valley, where coverage is actually not the issue, it's access. So we have a card that says Medi-Cal, and you go to a clinic and there is no doctor that is capable of treating your condition.
They're not accepting Medi-Cal.
Or they are not there at all. I think there's one medical license in Modoc County, for example. And so when we talk about this, we have to recognize where we are. Right now, about 6.5 million Californians on Medi-Cal. We're going to add another 3.5 million to that. But are we taking into account that we're going to have to get more creative, because at this time, about 60% of Medi-Cal recipients are having a hard time finding a doctor.
And I want to talk about that. And don't get me wrong, but I do want to go back to this insurance parity issue. Dr. Pan.
Well, certainly, having payment for services delivered over telehealth is going to be critical to sustain telehealth, right? Like any other part of, well, not only healthcare, but any sort of industry, right? You have to, people need to receive payment for at least the costs of delivering the service or good. And so that is going to be important. I think certainly parity is something that people talk about. This bill, the law actually, since passed, it's at least starts opening the conversation, takes down barriers necessary.
It actually seems surprising to me. I would think that if I were an insurance company, services delivered via telehealth would be much less expensive.
And one of the things, though, I think we also need to put in context is that as we're talking about payment, we are, in the larger scheme of things, moving away from a current payment system, which is very focused on encounters and procedures, and trying to move toward outcomes, things like the Accountable Care Organization pilots that are being done under the Affordable Care Act and others. So I think as we move in that direction, what's going to happen is that as we are looking at these types of issues, that parity issue may actually be less important over time, because what you were really talking about is outcomes, and there's going to be less of an issue about the insurance company saying, well, did you do it over telehealth or you did it some other way? It's like, did you achieve the outcome or not?
Do you agree, Mr. Monning?
Yes, so that's the direction we're moving towards. Affordable care organizations, the composition of different providers, experts from labs to treating physicians to nurses, etc. I would say that as we are in a system that's built upon payment for particular procedures, etc., one of the areas that will be the subject of negotiation in the short term was the use of telehealth or telemedicine. Was that for a laboratory test, for a retina scan or something like that? Or was there a treatment, was there a physician engaged in actual treatment using that medium, but for what would normally be a billable office procedure? So part of it, I think, is just going to be the evaluation of what was the service that was rendered using electronic means to do it.
Mr. Brown, was it disappointing to the California Telehealth Network that the 2011 Act did not mandate coverage for telehealth, i.e. create parity?
No. Let's put it in context.
Please.
This legislation is very unique nationally in
It's
terms
groundbreaking.
of beginning to take the steps to move in the right direction. We also understood going into it the state's fiscal condition and the need to be that we're going to be very cautious about moving forward with things that might have some financial impact on the state. So I think we're very pleased with the direction that the bill is going. By the way, I have at the California Telehealth Network, the insurers, the payers are on my board, as well as providers.
I would presume.
And there is a very healthy dialogue going on right now, frankly, about what is the economic argument that can be used across the system to verify that this is the direction we should continue to go. There's some very promising trials and pilot programs that have happened in specific areas of telemedicine. There are some others that the payers, I think, would say, I'm not so sure this is economically viable. And I think what's important is we do have a collection of stakeholders who are having these discussions and who are starting to focus in on what are the drivers that we ought to prioritize first here in California, and what are those that maybe merit further study before we decide whether or not we're going to do those.
Okay, so when we come back, I don't want to forget the conversation about Medi-Cal, because it is a very important one. I also want to talk about prison health care, because that's an area that seems to me could be a huge boon for the telehealth industry in terms of providing superior outcomes. We know the California prison health system has been under receivership, so we need help there for sure. We're speaking with Assemblyman Bill Monning, Assemblywoman Dr. Linda Halderman, Eric Brown of the California Telehealth Network, and Dr. Richard Penn, also of the Assembly. I'm Brad Pomerance. We'll be right back on Charter California Edition.
How many states permit reimbursement for telehealth services? 15, 25, 35, or 40? According to Practice Central, as of 2011, as many as 35 states allow for at least some reimbursement for telehealth services.
Welcome back to a special presentation of Charter California Edition, focusing on telehealth and telemedicine. My name is Brad Pomerance. This presentation is brought to you by Charter Communications, the California Telehealth Network, and the California Channel. We are joined by Assemblyman Bill Monning, Assemblywoman Dr. Linda Halderman, Eric Brown, the president of the California Telehealth Network, and Dr. Richard Pan, also a member of the California State Assembly. And I would be remiss if I did not go back and discuss Medi-Cal, which is California's Medicare program. We know, Dr. Halderman, that Medi-Cal has been cut dramatically as a result of severe budget crises in the state. In fact, Democratic Governor Jerry Brown is in a fight with the Democratic White House over further cuts. He wants waivers, he may not get them. But so talk to me about how the Medi-Cal issue dovetails into telehealth, especially in rural areas where jobs are being lost because of these Medi-Cal cuts.
What we know from Medi-Cal, which is our state's version of Medicaid, is that
Medicaid, yes, not Medicare, Medicaid. Thank you for that clarification.
Sure. What we know is that the lack of resources is forcing us to be more creative and to do more with a lot less. When I was doing breast cancer surgery in Little Selma, California, a breast cancer diagnosis and treatment visit and pre-op history was paid at a level of $24. It has since been cut to $21.60, and most recently there have been attempts legislatively to cut it further. But what we have found is that the courts are recognizing that it is not just cost concerns that we have to look at. We also need to take into account patient access when we're looking at budget concerns.
What have you seen, Mr. Monning, in terms of how the Medi-Cal budget crisis has dovetailed into healthcare generally, rural healthcare, telemedicine?
Well, it's emblematic of our state's budget crisis. Our revenues have dropped over 30% since the collapse of the financial industry in 2008, and we don't have a commensurate reduction in the need in education, healthcare, et cetera. It's growing. Right. So every dollar that California is unable to put into our share of Medi-Cal medical services, in many cases we're forfeiting federal dollars. So it's not a good situation.
So it's a double loss.
It's a double loss, and while we're trying to prepare the state for implementation of the Affordable Care Act, which is going to expand eligibility and access based on expanded Medicaid eligibility, translated to Medi-Cal in California, we are absolutely dependent on the implementation of the Affordable Care Act for the federal resource to help us implement Medi-Cal, expanded Medi-Cal eligibility and making more people eligible for that access. But we do have to be mindful, it's going to be an empty promise if the reimbursement falls below the level that providers can even pay the rent.
I mean, as we know, providers are simply rejecting Medi-Cal patients. I mean, we've discussed this.
Overwhelmingly in California, that's what we found.
Yeah, so what's happening, and as a pediatrician, actually, I practice, still currently practice and see a large portion of Medi-Cal patients. They're actually over half my practice. And so what's happening with the Medi-Cal system is, I think, as the previous speaker said, is that we are underfunding it. We unfortunately are dealing with a collapse in revenue in the budget. We have needs that are unmet that frankly require more revenue in the state to be able to meet those needs, whether it's healthcare or education or other fields. And I think that's a serious conversation the voters are hopefully going to be engaged in this year with the governor's initiative that's coming up. But I think also in terms of the other challenge when we have this payment issue, and again, I think as we know that there's fairly low participation in the Medicaid system, our Medi-Cal system, because of the low payment, that what happens is that we're having both delays in care, which can be more costly, and there's also frustration on the patient's end in terms of trying to get care, and again, that can cost more money in the long run. So telehealth, I think, is not certainly a solution to that. We still have to fix the payment problem.
Delays can also be life-threatening.
Sure, and delays can be life-threatening as well. And the greater cost is because now you need more intensive treatment because you've delayed it so long. But
I want to ask Mr. Brown if the collapse in state revenues and how that collapse has impacted Medi-Cal, is that impacting the progress of telehealth?
Absolutely, absolutely. And you have to know that of the 400 or so sites that we have enrolled, the sweet spot of who we really serve, this constituency, is the uninsured and the underinsured. It's not exclusively those groups, But that was the initial focus of our funding sources through the FCC and through Recovery Act funds that we receive. So when I go out and I travel into these clinics, you see firsthand how they are being impaired by the fact that the payment model for those populations isn't where it should be. In some of our communities, they are fortunate. They have local resources such as foundation money, or they happen to have doctors, specialists that are available to do work pro bono, but that is by far not the norm. And when we go in to some of these rural, and particularly the rural and the urban underserved areas, it's a real problem.
I want to ask Mr. Monning about the prison population. As you know, the federal court, I believe out of San Francisco, put the entire prison medical system under receivership. It has cost the state billions of dollars that it doesn't have.
That's right.
To follow the dictates of the medical receiver. How do you believe, and I'll open this up for everyone, of course, but I'll start with you, Mr. Monning. How do you believe telehealth can work to give superior outcomes to the prisoners and also save money for a state that really is broke?
Right. Well, you frame the challenge. California currently has over 160,000 prison inmates. Our prison budget has exceeded our higher education budget.
Right.
Under the realignment, which links to the federal court receivership on health care, under the realignment will reduce that prison population by about 30,000. We're in the progress of that. Nobody's being released ahead of sentence, contrary to...
Those low-level prisoners,
Right.
the 3 nons, are going to county jails.
They're going to county jails, not into the prison system. But in the healthcare front, it is a huge cost for the state. We are under constitutional requirement and U.S. Supreme Court order to improve our healthcare delivery ability in prisons. Telehealth can be a huge boon to this process. It can alleviate the cost of a 2-guard escort of taking an inmate from a locked facility to a local hospital or clinic. That said, we have to be very mindful that we don't sacrifice, again, that situation where direct inmate-patient contact with a physician or a provider is the best practice of medicine. In other words, we have to be careful that we're not just for the cost savings usurping the absolute constitutional right of an inmate to get the service they need.
Mr. Brown, have you been in touch with the receiver, the medical receiver, on this very issue?
Absolutely, and we're still having discussions, but I must say it's not as easy a discussion as the outside observer would think. And,
Really?
And you know, I'm not an elected official at the table here, so
So you can speak freely,
right? I will just tell you that there are people who benefit from the current arrangement who would not like to see it
Well,
change.
I'll say that I know that the California prison guards have been a little queasy about telehealth because their view is that they can get overtime if they are transporting a prisoner to a clinic that may be several hours away. So let's just put it out there. How do we deal with a very powerful...
I get a little bit uncomfortable when we start talking about, oh, it's the fault of one
I'm with you.
organized labor and public
Right.
safety, because
How
for
nice.
God's sakes, I do not want their job. They walk the toughest beat. There's no question. Also, as a physician who has treated prisoners
really?
who were handcuffed to the bed, I was trained at a county hospital. I like having protection for my own health. So I think we have to be mindful that sometimes our solutions are going to have to be even more creative, such as finding where the fraud is, such as getting creative in terms of generics versus brand names.
Right.
And I do think we have to make choices. Are we going to say that our felon population is a priority, or are we going to say that our child population is a priority? And I know where I stand on that.
I mean, you
Unfortunately, we can't make that choice under
Right.
order of the
Right.
highest court in
that
the
is
land,
true.
the U.S.
Well,
Supreme
Dr. Pan,
Court.
please.
Yeah, I mean, first of all, of course, prisoners do have a constitutional right to get health care, so, and that's why we're under federal court order around doing that. I think that, again, in terms of not only talking about the quality of care, but also being sure we meet the the safety of the prison not only the prison population, but the guards are there. So for
The doctors.
there needs well, not just the guards and the other staff that that when we're providing health care that there is this again, trust is going to be a big issue again in the care. But I think the other thing is, because we touched on realignment, is that what's happened is that also we've taken a population and for very good reasons. Place them in counties where there's a higher rate of a lower rate of recidivism, where they're more likely to hopefully be able to be productive members of society, not get in prison. Now, the challenge there is that you now are moving a population of people, of these prisoners, to the jails who generally are going to stay longer. They have longer sentences. So now the jails, you have a different set of population. You also have people who may be sicker.
Well, with enhancements, I mean, someone could wind up in a county jail for 5-10 years.
Right.
Well, if you look at our prison medical budget, there's a very small sector of older inmates with severe disabilities who are taking a huge percentage of our healthcare budget. If they had a medical parole option where they pose no threat to the community, they would immediately become eligible.
We have a law on medical parole, no?
Well,
or is it not?
We do. It's very restrictive. I did want to return to what I was saying about the realignment. Is that I think in addition to what we're doing, with the state prisoner population, as we're doing realignment, one of the things we should also think about, and sort of going back, touching on telehealth here, is that the county jails are also going to have a population. Potentially their health care needs will go up. Because you now, instead of having basically people who are there just for a year or two, you're now having people who may be there for 5 years, maybe longer.
I'm so glad you brought that up, because that is what we are experiencing in Fresno County right now. Is we have inadequate housing, and so we are going to be subject to the same limitations as the prisons. We are now seeing, because of capacity, our sheriff has no other option but to release people who do create more of a burden on society.
Just back to the telehealth component of this, the telehealth can offer a mechanism for diagnosis, lab testing, sharing knowledge, everything we've talked about before, and critical to patient health is the security of guards and the security of providers. My wife also treated inmates transferred from the Soledad prisons to the county hospital in Salinas, and they require 2-guard escort, handcuffed to the beds, and so the safety of not just treating physicians, but all of the staff, nurses, etc.
And I do think that as we're doing this very important work with realignment to meet the needs, that we should look at the so-called prison healthcare system. We may want to think about what kind of a system we create overall to be sure that we provide adequate care, and telehealth can be an important part of that.
In our final moments, Mr. Brown, is there connectivity to the state prisons for telehealth purposes?
There is. They actually have their own telehealth network.
So that's a net plus, no doubt.
Yes.
I want to thank all 4 of you for joining us. This has been incredibly enlightening, and I hope that when we meet in 3 years to discuss telehealth, it's only good news. I think it will be. It really feels like we're heading in the right direction, and California continues to be a leader amongst the 50 states in our great union. We have been joined by Assemblyman Bill Monning, Dr. Linda Halderman, a member of the California State Assembly, Eric Brown, the president of the California Telehealth Network, and of course Dr. Richard Pan, also a member of the California State Assembly. My name is Brad Pomerance. Thank you so much for watching Charter California Edition.